So good morning, everyone. It's my honor to welcome you in this room and watching online to Rare Disease International Slide for why prioritize rare disease in global health policy, aligning with World Health Assembly resolution on rare diseases initiative at the World Health Summit 2024 today. We'd like to give a special welcome to our distinguished guests from Minister of Health Belgium and from Minister of Health of France. My name is Alexandra Anderperi, and I'm the CEO of Rare Diseases International, and I will be your moderator today. Sheila couldn't make it for personal reasons. Please excuse me. So Rare Diseases International is a global alliance of people living with rare diseases of all nationalities across all rare diseases. And the mission is to bring a strong common voice on behalf of rare disease patients around the world to advocate for rare disease as an international public health priority and to represent its member and enhance their capacity. RDI has 116 member organizations from 48 countries that represent rare disease patient groups in more than 150 countries. So it's my pleasure to see several RDI members in the room today from Germany and beyond. And I also would like to thank IPMA, the innovator industry, for their support to this event. Our discussion today happened at an exciting time for the rare disease community as we gather support for a proposed World Health Assembly resolution on rare diseases, which call upon the World Health Organization to develop a global action plan on rare diseases. Initiated by the Arab Republic of Egypt and currently co-sponsored by the Kingdom of Spain, the State of Qatar, Malaysia, France, Panama, and Chile, this resolution will shed light on the challenges faced by more than 300 million people living with rare disease and will lead to achieving significant return on investments with science and technology in policy guided by principles of equity and empowerment in health system planning for optimized access to diagnosis and care, and in the social system resourcing to support people living with rare disease and their families. I would like to invite now our keynote speakers, Professor Mohamed Hassani, Assistant Minister for Public Health Initiative in Egypt, and then after Dr. Jérôme Wendlach, Deputy Director for European and International Affairs of French Social Ministries, co-sponsor both of the resolution to share their remarks about the importance of the resolution and the opportunity for global action.
Thank you very much, Alexandra, and very pleased this morning for you all. First and foremost, I would like to express my sincere gratitude to my esteemed colleague Alexandra for their kind invitation to give me the privilege to be with you today. And definitely with a strong partnership and leadership from RDI, Egypt, and Spain have taken the lead to sponsor a World Health Assembly resolution on rare diseases, co-sponsorship by Qatar, Malaysia, France, Panama, and Chile. A significant step towards enhancing the global response to this often overlooked area of healthcare. The forthcoming WHO resolution marks a historic milestone that calls for collective action and collaboration among member states. This resolution recognizes the unique challenges faced by patients with rare diseases and emphasizes the urgent need for comprehensive policies to address their needs. By supporting this resolution, we lay the groundwork for a global framework that fosters collaboration in research, data sharing, and best practices. Will represent a commitment to improving the lives of millions who suffer from these conditions, and we encourage countries to develop national plans, enhance access to diagnosis and treatment, and then to prioritize rare diseases within their healthcare agendas. Despite the anticipated progress from adopting the WHO resolution, we must confront the challenges that remain in the realm of research and development, limited funding, fragmented data, and regulatory obstacles hinder our ability to innovate and respond effectively to rare diseases. To tackle this issue, we must advocate for increased investment in rare disease research from both government and private sector, as well as philanthropic organizations. Collaborative initiatives that pool resources and expertise across borders will be essential in overcoming these barriers. Steve, that in these enrollment lists, we have several dedicated programs for diagnosing and care of patients with rare disease. And the Egyptian government approved this year the Rare Disease Fund, the governing body for the Rare Disease Program under the umbrella of the Universal Health Care. Yet we know well that the problem for those patients will never be solved unless we succeed to harmonize the efforts between several stakeholders, not only on the national level, but also in the regional and international levels. By aligning these efforts with the WHO resolution and the anticipated global action plan, we can create a strategic roadmap that improves access to treatment and care. And this approach will help us to build a robust ecosystem that supports research and foster innovation and ultimately enhances the patient outcomes. Finally, Egypt is committed to fostering collaboration at both national and international levels. By learning from each other's experience, we can create comprehensive strategic pathway that address the multifaceted challenges associated with rare disease. By conclusion, I invite all member states to join us in sponsoring this ambitious dream and to witness the delivery of this precious rare disease, which will influence the lives of millions around the world and can transform the landscape for individuals living with rare disease and build a more equitable and inclusive health system too. I thank you.
So, ladies and gentlemen, honored delegates, thank you so much, Alexander, to RDI for your kind invitation. Rare disease. Over 300 million people are affected worldwide, making them not rare at all. They know no borders, affecting people regardless of age, geography, or socioeconomic status. And yet, for far too long, they have been the forgotten challenge in global health. Many of these conditions are chronic, progressive, and life-threatening. They often cause premature death. 70% of rare diseases affect children, and delayed diagnosis prevent access to timely interventions. As 72% of rare diseases have a genetic origin, they also affect future generations. And yet, over 90% of rare diseases have no approved treatment. 90% of patients and families often face not only physical and emotional suffering, but also financial grief, and they struggle to find diagnosis, appropriate care, and access to treatments. Therefore, our common goal should be to achieve better health and well-being for all people living with a rare disease. This entails providing earlier, faster, and more accurate diagnosis, promoting universal access to health and social care through more efficient patient pathways, as well as cross-border healthcare cooperation. This will first and foremost strengthen our healthcare systems. Failing will not be just a failure for a particular health system. It will be a failure for global health as a whole. With coordinated global action, we can finally prevent millions of people from continuing to suffer in silence. The first ever UN resolution on addressing the challenges of persons living with a rare disease and their families in 2021 was the first stone. We need now a clear direction for concrete actions to strengthen our health systems and improve the life of millions of patients and their families. In many parts of the world, especially in low and middle income countries, rare disease patients face severe barriers and treatment. This inequity is not acceptable anymore. Collaborative approaches that no single country can tackle alone are needed. Research and innovation efforts are often fragmented, data are scattered and heterogeneous, and resources are insufficient. Coordination action will promote collaboration, data sharing, and joint research initiatives, allowing us to improve access and accelerate the discovery of new therapies and diagnostic tools. Therefore, France is alongside RDI and our partners countries such as Egypt to urge the global community to take a decisive step forward and through a global action plan on rare diseases and a resolution on rare disease at the upcoming World Health Assembly in 2025. The strategy underpinning this plan should include the following elements: investing in multilateral fora at the G7, the G20, the World Health Assembly, and UNGA, so that rare diseases are identified as one of the main issues on which we want to make progress between now and 2030. Second, progressing at regional level. Supranational political organizations such as the European Union can play a major role in as a sounding board for coordinated action on rare disease. France will continue to campaign for the idea put forward by our former Health Minister, Catherine Vautrin, that a rare disease plan for the European Union is essential. It will enable the EU to share its experience with other regions of the world. Third, engaging in bilateral partnerships for infrastructure projects, training, exchange of best practices and data, research and care to support the countries that need it most. It's time to act. We have the knowledge, we have the tools, and we have a moral and ethical duty to change the life course of millions of people affected by rare diseases. A global action plan and a resolution at the next World Health Assembly will not only improve the lives of patients, it will strengthen our global health systems, making them more resilient and equitable for all. Let us commit today to shaping a future where no one, no matter how rare their condition, is left behind. Thank you very much.
Thank you very much, Professor Back. Now we turn online to hear a message from Dr. Mónica García Gómez, Minister of Health of Spain, co-sponsor also of the resolution, Dr. Mohamed Al-Thani, Director of NCD, Non-Communicable Disease Prevention Program Department, Ministry of Public Health State of Qatar, and finally the Chair of RDI Council, Kristen Johnson.
Hola a todos y todas, es un honor dirigirme a ustedes para reafirmar el firme compromiso de España con la adopción de una resolución en la Asamblea Mundial de Salud sobre enfermedades raras en el 2025. Esta resolución pretende dar a las enfermedades raras el espacio que merecen en la agenda internacional, así como marcar un antes y un después en nuestro compromiso global por mejorar la vida de más de 300 millones de personas en todo el mundo que viven con estas condiciones. Las personas que padecen una enfermedad rara se enfrentan a enormes desafíos diarios, retrasos en el diagnóstico, dificultades para acceder a tratamientos, estigmatización social y una enorme carga económica. Estas son las realidades que afectan profundamente no solo a los pacientes, sino también a sus familias. Aunque hemos logrado importantes avances, aún queda mucho camino por recorrer. Sabemos que existen alrededor de 7.000 enfermedades raras identificadas, siendo 400 de ellas las que afectan al 90% de la población con estas condiciones. Mientras tanto, miles de enfermedades raras siguen sin ser diagnosticadas o tratadas. Y esto tiene que cambiar, y este cambio debe comenzar ya. En el 2019, la ONU subrayó la importancia de incluir las enfermedades raras en las estrategias de salud global. Y en el 2021 dimos un paso fundamental con la adopción de una resolución internacional. Pero sabemos que para que estos compromisos realmente mejoren la vida de las personas, necesitamos mucho más que palabras. Necesitamos un esfuerzo global y coordinado, una hoja de ruta ambiciosa que guíe nuestra acción y que asegure que ningún paciente queda olvidado. España está comprometida con esta causa y lo hemos demostrado con hechos. En nuestro Sistema Nacional de Salud hemos desarrollado modelos de atención que ya están marcando la diferencia y que pueden servir como referencia a nivel internacional. Ejemplos como los CESUR, que ofrecen atención integral y especializada, nuestra participación activa en las redes europeas de referencia y proyectos como Únicas, que se centra en enfermedades raras pediátricas, son una muestra clara de que estamos avanzando en la dirección correcta. Además, hemos ampliado el criado neonatal para incluir 23 enfermedades congénitas a partir del año 2025, lo que supondrá un avance crucial en la detección precoz y mejorará la vida de muchos niños y de sus familias. Pero, a pesar de estos logros, somos conscientes de que queda mucho por hacer y nuestro objetivo es claro: Movilizar el apoyo internacional para lograr la adopción de una resolución en la Asamblea Mundial de la Salud que nos encamine hacia un plan de acción global sobre enfermedades raras. Esta resolución debe garantizar el acceso equitativo a diagnósticos y tratamientos y abordar de forma integral las necesidades de las personas que viven con estas enfermedades y las de sus familias. Sabemos que el camino hacia este cambio es global. Solo será posible si trabajamos juntos, con enfoque multidisciplinar y colaborativo, uniendo fuerzas entre gobiernos, organizaciones internacionales, profesionales de la salud, investigadores y, por supuesto, poniendo a las personas afectadas y sus familias en el centro de nuestras acciones. Hoy contamos con la oportunidad de transformar la vida de millones de personas. La ciencia, la tecnología y la cooperación internacional están de nuestro lado. Es el momento de actuar y es ahora. Muchísimas gracias.
Ladies and gentlemen, distinguished guests, and tireless advocates for the rare disease community, it's my honor to address you at this pivotal moment where we gather to highlight an issue that demands urgent global attention: rare diseases. Today, we come together to discuss how we can and must take bold steps to ensure that every person affected by a rare disease has access to the healthcare, support, and dignity he deserves. Rare diseases impact the lives of over 300 million people worldwide. While each condition may affect only a small number of individuals, the collective burden is immense. The challenges faced by patients and their families are many: long diagnostic journey, limited access to specialized care, and the emotional and financial toll that often accompanies these conditions. Yet, despite these obstacles, the strength and resilience of the rare disease community inspire all of us. In Qatar, we understand that health is a fundamental human right, not a privilege for the few. Our national health strategy is grounded in the principle that no one should be left behind. It's this belief that drives our commitment to ensuring that rare diseases are integrated into universal health coverage. We must work together to guarantee that every person, regardless of the rarity of his condition, has access to timely diagnosis, effective treatment, and comprehensive care. Allow me to share an inspiring story from Qatar. Many of you may know Ghanem Al-Muftah, Qatar's FIFA World Cup 2022 ambassador. Ghanem was born with a rare condition called caudal regression syndrome, CRS, which affected the development of his lower spine and limbs. Despite the challenges posed by his condition, Ghanem has become an icon of hope, resilience, and determination. He is a successful entrepreneur, a motivational speaker, and an advocate for people with disabilities. His message during the World Cup 2022, one of unity, inclusion, and overcoming adversity, resonates globally, reminding us of the incredible potential of individuals living with rare diseases. His story exemplifies what is possible when such people are given the support and opportunities they deserve. It also underscores the importance of early detection, accessible expertise, and collaborative care, all of which are vital in addressing the unique challenges faced by those living with these conditions. Qatar is committed to addressing these challenges head-on. We are proud to collaborate with institutions across the globe to advance rare disease research, strengthen diagnostic capabilities, and develop personalized treatment. Our partnership with leading health organizations and academic institutions has enabled us to make meaningful studies in this area. For instance, the integration of screening into our national newborn health programs has been a key initiative aimed at early detection, giving our youngest citizens the best chance for a healthy future. However, our efforts must go beyond the national borders. The World Health Summit is a unique platform for global collaboration, a space where governments, civil society, academia, and the private sector can come together to share knowledge, foster innovation, and create lasting solutions. It is only through this partnership that we can address the profound healthcare challenges posed by rare diseases. As we move forward, I urge all of us here today to commit to a shared vision where diagnostic delays are a thing of the past. where these patients are no longer face isolation or stigma, and where equitable access to treatment is not a dream but a reality. To achieve this, we need to coordinate a global action plan that addresses not only the medical needs of persons living with rare diseases, but also the emotional, social, and economic support they require. In Qatar, we have embraced the importance of multidisciplinary care centers, where experts from various fields work together to provide holistic care. But we know there is much more to do together. We must continue to invest in research, not just to develop new treatments, to understand these conditions more deeply, and to uncover new ways to prevent them. Our research community is playing a vital role in a global effort to find solutions for the most complex and rare conditions, and we encourage other nations to join us in this quest. This event is a powerful reminder that while we may come from different countries and backgrounds, our goals are the same. We are united by our desire to improve the lives of those affected. Together, we can make sure that the rare disease patients are not forgotten in the global health dialogue, and that they receive the care and attention they deserve. To all patient advocates, researchers, public health professionals, healthcare providers, and policymakers here today, I thank you for your tireless dedication, your work in changing lives. It is through your passion, determination, and collaboration that we create a future where every person with a such condition has the opportunity to lead a full and healthy life. To conclude, let us leave with a renewed commitment and action. Let us work hand in hand to ensure the health system across the world are inclusive and equitable. Let us raise awareness, reduce stigma, and advocate for the rights of those living with rare diseases. And above all of this, let us ensure that the future of global health is a future where no one is left behind. The true measures of a society progress lies in how well it cares of its most vulnerable members. Thank you for your commitment, and I look forward for the impact we will create together.
I would like to begin by saying thank you on behalf of the Council of Rare Diseases International to the member states who have supported this resolution for rare diseases. This WHA resolution will make a real difference to everybody around the globe who lives with a rare condition. Thank you to Egypt for initiating the resolution, and thank you to Panama, Qatar, Malaysia, France, and Spain as member states who are supporting this resolution. Together, we can make a real difference, bringing equity to all those living with rare conditions. As a parent with two young women who live with Fragile X syndrome, we know the diagnostic odysseys that many families face. And indeed, many families never do get that diagnosis and are living with a rare condition and no support. There is so much need when it comes to accessing healthcare, accessing expert advice, accessing medicines. And this discussion today will be really fruitful in bringing together leading thinkers, policymakers, healthcare providers, pharmaceutical industries, and those who with financial nous to support these initiatives. So it's exciting to have an event like today to bring together leaders, and together we can make a difference. So thank you so much for supporting this WHA resolution, and thank you for helping us move it forward.
So thank you to all our keynote. Now going back to live here. So I will now introduce our panelists. So Giscard Behr is the Secretary General of RDI, Rare Disease Europe, and Chairwoman of Access, Rare Disease Germany. Giscard's elder son suffers from an autosomal recessive congenital ichthyosias, and she's been involved in German patient organization since 1997. In 2004, Gelke started working towards funding a European network of its authorities sorry for the position here, which was legalized in 2010, and for which she currently serves as chief executive on a voluntary basis. Getke is a powerful advocate for rare disease patients working across grassroots to policy level. Then we have Alba Parejo, is a member of the board of directors FEDER, the Spanish Federation of Rare Diseases and Patient Advocates. Alba has worked extensively in raising awareness about rare disease and mental health, specializing in patient advocacy and in social media management. Her work as health communicator has been recognized by the World Social Media Awards in 2024, where she was awarded the European Prize for Social Media Outreach. Next to Alba, we have Dr. Rüdiger Beck, is the Director of Health Promotion at the World Health Organization. He leads WHO work on tobacco and alcohol control, physical activity, and enhanced well-being, and the program of Living Health Law and Fiscal Policy for Health. He had previously been directing the work on health systems and universal health coverage, and has been instrumental in developing the public health work on social determinants of health, and is the champion for rare diseases in WHO. And finally, we have James Anderson, leads IFPMA work spanning global health, including the innovative pharmaceutical industry policy on pandemic preparedness, antimicrobial resistance, and global access to medicines and vaccines. James is chair of the IMR Industry Alliance Board and chair of the Entry-Pi Alliance Board, and has also served as the vice chair of health and business at the OECD and as a member of the UK Life Science Strategy Board. So we're going to start our first discussion that is going to focus on innovative model for rare diseases. And actually, we heard from all the keynotes the term of collaboration and innovation. So with the concept of precision medicine on the rise, the rare model is one that brings actually innovation and new thinking, because we have no other choice. New thinking of innovative solutions that bridge gaps and ensure equitable access to healthcare for individuals. So RDI believes that addressing the challenges in rare will actually have impact and provide learning that can be even applied in other healthcare challenges. So with this in mind, I'm going to ask my first question to Rüdiger. Rare diseases have many challenges, and in your experience and role at the WHO, why do we need innovative collaboration models to address those challenges? And are there any examples of this in the non-rare disease area, or even in the rare that you are aware about, you would like to share with us?
Thank you, Alexandra, and a very good morning to all of you. So when I just entered this room, I was actually reminded of a situation very similar to this in 2003, 20 years ago. And we started with this fine group of experts and member states on social health insurance, which then became universal health coverage. And I'm saying this because we have the sort of same setup here today with a couple of member states, so Spain, France, Egypt, Qatar. Time it was France, Japan, and Germany, and I was actually on your side, I was in the German government, and we had all these fine experts in civil society organizations saying it is a moral requirement that we have access for all of health services if they need it. And here, so we do have a challenge of advocacy. We're here in this small room. We're not there in the plenary yet, where we are with universal health coverage. And we will be if we're smart enough to organize ourselves and to promote this cause, this good cause. Now, there's a little bit of difference in advocacy work, what we've done on universal health coverage and what we need to do on rare disease. Because the issue in universal health coverage, we started with the finance. We said, oh, if we have a social health insurance system, whether it's financed through taxes or through contributions, all the same, doesn't matter. But we need to have pre-financing mechanisms to make universal health coverage possible. And only then, after we started with this financing, we saw that perhaps we also need to work on health workforce and delivery systems and so on and so on. So also here, and that is the same and difference with rare disease. Because in rare diseases, we have a couple of challenges. These challenges, we're going to talk about this during the session, are, for instance, the centralization of expertise, so the gravity, but then therefore we need to centralize the expertise. And for this, we need innovative technological approaches that we have. And that's one thing, but it will not work if we're not at the same time work on sustainable finance, so that the centers of excellence will be remunerated for the work they're doing internationally, just not nationally, but it calls for an international arrangement how we're going to finance. And we cannot finance this through a fund or anything, because that will not be sustainable. We need to finance this through the mechanisms we have now, through universal coverage, through the health systems themselves, so international agreements on the financing. And then we need also to work with the pharmaceutical industry and the community, because at the moment only 20% of people with rare diseases have actually access to medicines that they need. And that is a complexity in itself, because there's, of course, no real incentives for the pharmaceutical environment to actually work on research and development, because we have bigger issues in other diseases. So therefore, the priorities in R&D in the pharmaceutical community is set differently. So therefore, we need to create those incentives. And there's, of course, a lot of other complexity, but shy away from all the complexities in developing appropriate medicines. There's the data issues, there's the last mile issues of delivery. But I'm sure that together, and that comes back to Alexandra, what you were saying, and the other speakers as well, to collaborate. So here now, the thing is the following. In universal health coverage, we could do one thing after the other. We'd start with financing, then we looked at human resources and service delivery mechanisms. And so we could actually develop this complexity one after the other. Here, we need to work in parallel. And that's the next step in universal health coverage. If we are serious about universal health, then the first billion people we got in the mechanisms we have. So in the next phase, we need to address the second and the third billion, which still do not have access. That's by and large people. Right, so that is the next stage. We need to understand that from a health systems point of view. This is the next stage for universal. And that means then also, and then I'll stop, is in the advocacy work that we're going to do with other members. We want to convince others to join us in this journey. We need to understand that only if we have that systems approach to it, that we start seeing how the different parts relate to each other, then we can make this next step, the next level of universal. That is why then the moral input obligation comes into play. Because we had heads of government who agreed to university. Thank you.
Now to have that, from a patient perspective, what is needed on policymakers and others to implement this approach so that people living with rare disease globally are able to benefit? Thank you, Alexandra, and good morning for all. First of all, I would say that when we're talking about rare diseases, We are not just talking about the patient, we are talking about their family, their classmates, their workmates. So it's a global problem that we are facing all of us in this table. So we need three key measures, and it's a mix of things that you are saying. So first of all, we need a collaboration with all the countries, with all the member states. So in that way, no single country will be behind us. So we could share all the resources that are available, all the information, so we could generate newer knowledge and guarantee an equity in access to the treatment. So there's an example that we have seen this recent years with, for example, the COVID. The second is the collaboration with the professionals and the research community. So we have seen different examples in the European network. So that this innovation, putting all these items together, makes a newer knowledge. And finally, the incorporation of the patient representation. For example, being a patient or being a parent of a patient or a sister, or putting the patient that it's something that affects us. We are the people that have the disease. So today we are in Berlin, but we have been in New York, in Geneva. And it's a clear example of how patients, we are transforming society. We are giving our voice, we are saying what we need, and this is a clear value that we need to be in the decision-making processes with all these items. And so we need this collaboration with all the patients, with all the countries, but it's coordinated with all the agents. So we could make a framework to work to solve a problem that affects us. Thank you.
Thank you, Amber. To Giskin, in little over 5 years, European reference networks have been a real success for rare disease. I understand there's some challenges, but still. Can you describe perhaps 3 key lessons from this that could be replicated in a global activity at global level?
Thank you, Alessandra. Good morning to everyone online and in the room. Actually, I think the most important thing for European reference networks is that everyone wants to put. Everybody has the willingness to give and to take. And what we need and needed and will need in the future as well, via the action plan, the European action plan, we are calling for, of course, as well, because we need an overarching structure, something that gives a framework so that every stakeholder, everyone involved, whether it's pharmaceutical industry and the researchers, the patients, or the doctors and the hospitals themselves, that they are very confident that all their efforts and time and money they invest are in a good place and will lead to something good. That's something that works with the ERNs already pretty well. Of course, they are still in their infancy, although they are now 7 years, it's 2017, that they started. Still they are in their infancy, but you can see a lot of progress because the patients are in every ERN, there's patients on every level of the medical level as well as the research level that are being asked, what really do you need? What is the thing which is annoying for your disease? Maybe it's not itching, maybe it's something completely different, but we thought it was itching, or the other way around. This is really important to have the patients at all stages. And we did that, and it's working in most of the ERNs very good. There are some where it's of course a bit different, but that's everywhere because it's different cultures. That's something we should not forget in all our plans and all our discussions. It's very different cultures, even within Europe, and I think globally, it's even a lot more. And just like you said, Alba, it's not only 300 billion, it's more than 1 billion in the end that is affected by rare disease. Because you have the patients and everybody around having the financial rim, having the time problems. There's a lot of people that cannot work because they have to take care of a relative. So, but for the ERNs, the most important thing was the framework and that we had a very strict plan how to implement them. They are not implemented in all the national healthcare systems yet, which is a shame. And I have to admit, in Germany, they are not yet fully implemented, but it's a long progress, a long process. So it's work in progress, and they are to be supported better in the near future. But this is really something I could imagine on a global level as well, because it should not be the patient traveling. To centralize the expertise is great, but you have to have also this as a hub for everybody else, so that the information and the expertise can travel, and that's not the patient. And that's working very good with the ERNs.
Thank you very much. Okay. Then question to James. Well, it's still happening that still today only 5% of rare disease have a treatment option available. And so given the challenges in research and development in this area, what type of innovative models and partnerships are needed to help change and increase this larger percentage, and what it will take?
Thank you, Alexandra. It's early Sunday morning challenge. So I want to start off by just dialing back. 30 years ago, roughly, I was an undergraduate in university studying science, and the cutting edge topic was genetics. The early stage gene sequencing was just saying there was blotting techniques. The academics was starting to unpack the power of genetic understanding. And then we play forward with the human sequencing was a very big step, but still an academic step largely, right? It didn't directly trigger any new medicines or anything else. Then 10 years, roughly 2 decades later, in 2016, the first ex vivo gene therapy was launched. Some of you may remember this was for a very rare disease, ADA skin, right? Really nightmare disease. But this was extremely rare. It's not a few patients in the world. So what I'm saying is, and then that technology now, another decade later, is used in many more diseases, in a wider range of diseases. It's CAR T therapy that we all hear about more commonly is a comparable technology. So what am I saying? I'm saying, first of all, it takes time and expertise and long-term effort from the research community to go along that journey. That's a 30-year journey. Now, so that's the first point. The second point is, where we are now is actually very exciting from the potential. These technologies that have been built along that journey are starting to be deployed. And the potential is very significant. So I'm not saying that is going to magically transform the 5% into the 95%, but we do have now a number of new tools and technology platforms that have the potential, and we can all see that. So how do we accelerate it? How do we unlock it? How do we untap it more broadly? I think I want to just put on 2 things that other have already said. First of all is the data. So we know the data is even epidemiological data for rare diseases in many places is not there. So the IFPMA, with a number of our member companies, some here today, have been working with RDI to look at the socioeconomic burden of rare diseases in lower and middle income countries around the world. And we knew going in there was going to be a challenge because the data isn't there. Sure enough, that was the case. But we have been able to show that there are comparable burdens from an economic basis on countries in all levels of the income spectrum. And so the data point has been highlighted already, clearly remains an issue and something that is necessary to help part of that acceleration. And then the other thing that I do think can help with the acceleration is thinking about really this issue that was raised at the end of how does the treatment get delivered? With the ADA SCID gene therapy, there was one center in Europe, in Italy, in fact, which had the capabilities to do that. And in a way, I hear Jessica very much what you say. I feel it's a really important challenge of how do we do that? How do patients get diagnosed? First of all, without that, we're nowhere. But secondly, even then, you need expertise, which does require a level of concentration. And I agree with the regional approach. And yet what you say at practical level is also fully true. So on that one, I don't have an answer to it. I think discussions like this are very important so that we can agree what's the best balance. Clearly, not all diseases are the same on that balance. And so we shouldn't try to have a one-size-fits-all approach, but enabling and seeking to find the best balance that delivers that new technology to the patients in the best way is clearly what we will seek to do.
Excellent. Challenge accomplished. Thank you very much. We're going to have a second round of discussion now, and after we will open for reaction and also question from you. We are a small group, so it's really the occasion perhaps to take the opportunity to discuss between one another. So the second round of question is actually going to be focusing on more health system. Rüdiger had already touched upon that, but basically, what do we consider as innovation in the perspective of financing? We know it's one of the main challenges for system funding. So how new models really are needed globally to respond to this challenge in financing for rare diseases and to increase UHC. I definitely fully agree that it's a health system issue that also needs to be fixed. So first question to Rüdiger on this, obviously. And again, someone who has experienced really many challenges in the global scale in health system. I'm sure that financing healthcare is one of them. So in your experience here, what lesson can the rare disease community take from this that address the financial challenges in particular? And I know you already kind of mentioned, but can we go a little bit deeper here?
Sure. So when we started looking at how can you finance universal health coverage, a lot of member states said we cannot afford it. Leave us alone. And then we said, oh, great. So how do we make it more real? Is it really the case that we cannot afford? So what we did was economic analysis to see what's the financing gap globally. So how many countries could and could not afford universal health coverage? And then we found out that the gap is not as big as we thought. It was 100 billion US dollars. And so when we then talked with different member states, they said, we have no interest whatsoever to create yet another fund to actually pay for health services carried out in other countries. This needs to come from the health systems themselves. But then we said, would you be able to actually close the gap? So over time, so to say, we're starting because we see that there are some real issues in finance. Some countries really are, which is much lower than we thought. But would you actually, if there's a concrete plan, how you put this on sustainable grounds, would you be willing to actually reduce that financing? Member states said yes. And so there were a lot of economic transactions in the first place based on monitoring systems that actually looked at are you now working as member states to actually secure funding system. So this is how we now, 20 years later, have actually managed to have 700 million more people in universal. So My advice would be to also look at the failures, because we had some mechanisms where the pool of services were very small. Once there was a big health crisis, they got bankrupt. They went bankrupt. So it didn't. So let's be clear on that. So what would we need in terms of finance is that, as we said, it's the centers of excellence who actually diagnose, but also share the information so that it becomes available. And then work with those people with the technologies we have at hand through telemedicine, e-medicine, ML, or not all these innovative things that we now need to apply, which weren't there 20 years ago, which are available today, which yes, but it's to make it then available to the people in other countries, in the local, so the GP in a village somewhere has access to the center of excellence and be in touch so that they get advice, medical peer reviews and advice on what to do with this particular patient. This is possible today, but this costs money. And so therefore, perhaps there need to be international agreements. We have agreements. The good thing, we know how it works. In Europe, you can get care wherever you are, where you actually choose to live. And that is then remunerated between the different EU countries. You have a pooling system in PAHO in the South Americas for purchasing medicines, where there's bilateral and international agreements that actually rule this game. So therefore, perhaps there could be other international agreements where you say, the only way how it works is that the centers, wherever they are in the world, need to be remunerated on an appropriate, reasonable funding. And there perhaps could be an international agreement between countries to say wherever this person is, but that service will be remunerated. So therefore, we really can centralize the knowledge, the services of diagnostics, the genetic testing that you might need, the innovative technologies that you need to apply. But by and large, they are not the most expensive ones we have in health systems, very often not. So perhaps we can start small by identifying what can be remunerated so that we have, like in universal health coverage, that we have a very defined package of services that could be accessed through these international agreements, through these centers of excellence. And then we can enlarge later on once we see that. Yeah, so these are my 2 cents of whatever.
Yeah, so Ada, this financial difficulties we also mentioned earlier, that is the burden on families. What is the impact really that you've seen personally, but also in the community, and how can then a global action plan, we have to talk about that today, will help to address this impact? And what should we prioritize? Because indeed, we need to prioritize.
Well, I would like to explain like a little story before I answer this question. 2 days ago, I'm a patient, so I have a rare disease. And 2 days ago, I was in the hospital, and my dermatologist asked me if she could like make me a little medical intervention to take a little 4 milliliters of my skin, nothing.
Sample.
Yeah. And then for me it was like super, because yeah, you can do it because in that way you can understand what is happening in my skin. But at the same time, for me, it's like a trauma, emotion, because all of my past of all the interventions. So when my first thought was, I hope that one day I will arrive in the future and doctors will know what I have. So then I will not have to do that little intervention. Because for me, it's like, we are not just talking about medicine, because we are talking about quality of life.
we are talking about all the mental health, for example, transportation to the hospitals, and so on. It's something that families have to cover in their economy. So a big part of their economy, my economy, is to pay our day with the living. So for example, in Spain, the national health system cover a big part of these medicines or treatments, but not all that we need. And for example, this is not the case in all other parts of the world. For example, Latin America is one of the examples that they are not covering nowadays everything that they need. So when we are talking about medicines, we are talking about this economy that families have to put, and also patients need to, maybe they cannot work because of the disease, or maybe there's a parent or a mother that needs to work because these people are difficult is carrying the work. So that global action plan would put this problem in the public agenda. So it would say we have a problem, we have a social problem here, and also all the member states would allow access to that treatment that are available. And that approach is currently made because of the associations. When a family creates association, it's because there is a problem that is not resolved in the government. So that psychologist approach, that economic is made by locally, national, and globally because of the federation. Because we wrote this federally. So this global action plan will support and give answers to that question.
Thank you. Thank you very much. To Cascade, what can be done through, again, a global action plan to address the barriers in access to innovative therapies? There are barriers. Are there any specific solutions that you feel could be developed on a more global scale? And if we had to prioritize, what would it be?
Well, the problem with the innovative medicine is that most of it is really expensive because it's very complex research, and then the medicine is not easy to produce and stuff like that. So this is really going to be a problem. It is a problem already in Germany. We used to have access to anything that EMA gave market authorization to. We still have, but they put down the limit. So it was, until now, it was 50 million. And then you had to do the full process for marketing authorization in Germany, which means you had to show that it's better than anything that's there, and it's cheaper than anything that's there, stuff like that. So the whole EMA process in Germany, again, HTA, from the very beginning, used to be 50 million, now 30 million. Which means for medicines that are expensive, it's going to be within 1 year, not within 5. They put down the marketing exclusivity down to, I think, 7 years now, from 10. So in Germany, they're pushing back because of a lack of money. And if Germany has a problem with the lack of money, which is a very rich country compared to many, many others globally, I think this is going to be a problem. And we will have to find solutions to that. But I don't have an idea. I'm sorry.
No, but
Not at all.
it looks why we need to collaborate even further, and it's better really to think about it. So the next question, then we open to discussion. Jess, do you have any example where innovative partnerships, such as public-private partnership or product development partnership, has developed innovative financing to support both research and access in rare diseases?
Yeah, thanks. So I wanted to actually, again, before start a bit broader, because rare diseases, each rare disease needs a different treatment, different diagnosis pathway, different patient pathway. And I think the small numbers can be an advantage in some ways when it comes to. On the other hand, the 300 million number, big number. And so I think one of things as we go into this planning phase is just to be really clear on the pros and cons of having a big number against actually what are very small. Because Rudy, as you were saying, and certainly what we see is small numbers can still quite often not be below the budget threshold, I guess, that you mentioned actually. But there's a very practical point to focusing on small numbers. Secondly, again with my example of SCID, which is very, very small numbers, that meant that the most cutting edge technology could get used there first. So I think this balance of there are pros and cons of having small numbers and also having a big number when you add a lot of small scale. Secondly, I think we've heard from several governments, online and yours as well, there are clear recognition that an approach to having funding available to get patients through the pathway from diagnosis into care requires some different approach. And I'd love to hear a little bit more about actually your funding that you introduced, because that feels like it's probably a good model that others should have, right? But, and we also heard that this balance of the local, very local, or as local as possible, with the aggregation approach. So to delivering care. So on that one, it feels like we're all trying to say the same kind of thing, but how to actually implement it still remains a challenge. Certainly when you have a global action plan. My concern a bit is that we look for one size fits all solutions, that it's not that simple, right? So then, just to come back to your question, I think there are all sorts of different examples, not one size fits all, but where companies do develop treatments or technologies and apply technologies in different ways with different partners, often with in this area often with patient groups actually as the key, cystic fibrosis being a good example. But there are many others, different models, which bring in funding from different sources, trying to accelerate the research, gathering the data to get critical mass, identifying patients to come into the studies, working with the regulators collectively to make sure there's a clear pathway for these treatments, which often, again, that doesn't exist until we make it happen. So I think there isn't a single answer to your question. I think a lot of good examples are already happening in terms of the collaboration to accelerate it. And I mean, maybe I also invite my colleagues here to report specific examples they may want to share, because it is happening. We can do more, and we've committed to do so.
Thank you. Excellent. I think we have a lot of food for thought, I was going to say, but not to discuss. But first of all, thank you. I'm going to open the floor for remarks and discussion, but we have actually a participant is from India. It's Mehu Jain. He's a master's student here in Berlin, where he's part of the Hemophilia Leadership Program and a member of the Hemophilia Interest Group. So back home, you have been in the regional youth representative for the Hemophilia Federation of India, and also a youth volunteer worker for the Hemophilia Society in Bangalore, chapter for over 12 years. And so along your professional experience in healthcare, pharma, and supply chain, Mehu, can you explain a little bit the challenge you've been through? And then we'll definitely open to everyone for questions.
For sure. Thank you so much, Alexandra, for the introduction. So I am a hemophilic patient from India, and the challenges that are faced in the country do include, I think it overlaps a lot with what Alba had to say, right? that it's not just the patient, but it's also the families that are affected. Along with supply chain and the lack of medicine, there's been a tremendous increase in the availability of medicine, but it's far from where it has to be at the moment. What I see that there's a technological gap, right? Sometimes access is not easily available because health in itself is a state subject in India. So you already see a bifurcation, and there is no central body that says that health's supposed to be, our thing. So it's noticing that we are in a place where we're trying to get something centralized. I think that is a really good approach. And some more problems that are faced is the bureaucracy in India, trying to get everyone into a room together and explaining that we have this issue. So we have a patient body, we have the government, and then we have the pharma. And these three in collaboration, we are able to, take steps forward. My experience in Germany, however, has been a positive experience, wherein I'm able to get better access to care at a much faster and easier way. That means for the time that I've been here, I have seen a considerable improvement in my health, right? And it's really, really a positive experience that I would like to share. And I only wish that everyone could have the same sort of access, but it's not practical at the moment. Also another difference that I notice is an outlook towards treatment. And this outlook is that I see in the EU, it's more about prevention rather than cure. But back at home, it is about cure rather than prevention. Once you're hurt, we'll deal with it. It isn't that, don't get hurt at all. So I think we need to address health as a prevention as well. And the last thing that I would like to share is about side effects and not just the disease. For example, being a hemophilic patient, I have 2 arthritic ankles, and that has developed over a span of years. And we all talk about in the hemophilic community about factor or the medicine, or just getting the main medicine into our system. But then we forget that we also have issues like joint damage, mental health issues, lack of education. And I think when we talk about treatment, we should also talk about healthcare as a whole rather than just the disease or that particular medicine itself. So I would like to know what you guys like to.
Thank you so much, Leon. This is really about integration also of diseases into the other healthcare system. So really thank you for bringing this, because it's something that I hope the resolution and the action plan will also take forward. Now we open the floor. I'm sure there are many people here so involved in the rare disease space that would like to perhaps react or raise a question to our panelists or keynote speaker, or even our keynote speaker if you want also to react to what you heard. Welcome. The floor is yours.
Just allow me to respond to James' question about this funding, because it fits also new questions in terms of having why we need a global action plan to build a kind of financing mechanism. So in Egypt, we have a very fragmented pathways for care in patients with rare disease, and we have some very simple movements aiming for diagnosis and treatment of certain diseases, like most of them have a group of disease. And so far, the dominant story in Egypt that anyone suffering from rare disease should go to the court asking for a legal dispute with the government. And then the judge will decide to give him the governmental obligations to treat these patients. He go to the financing department, department side the Ministry of Health or the investors insurance organizations to be funded. It's a hassle, long pathway, and this is a repeated story not only in Egypt and a lot of times. So the patients with rare disease to feel that it's not their mistake. I don't care that my disease is present in 1 million, 100,000, even like the history of hypertension to be treated equally like diabetes. This is the main issue that need to be addressed. So the rare disease fund in Egypt come after several national discussions and dialogues to take account that we could have access. Egypt now is transforming itself from being without universal insurance system. Now, the Egyptian law should be fully transformed until the year 2032 to cover all the Egyptian government needs. And this law obliged to make a kind of a deduction, 1% deduction from the net prices or net salaries of the cosmetics that is sold in Egypt. It's a very tentative or primary decision inside the law, but we're trying to pull more and more reductions in order to pull more funds to be able to diagnose and treat the patients with rare disease. And the idea also of having this rare disease fund is trying to make a kind of workaround solution, because if we're speaking about, if you talk about the HTA departments and several entities, and told them that you should treat, for example, 10 patients with $1 million, they told you that this $1 million can treat X amount of cancer patients or X amount of patients with renal dialysis. So we need to have a very innovative way of funding to avoid all the obstacles in the regulations and affordable medicines for the access to therapy. We realize that it's not a 100-meter race, it's a long marathon. Should go along together to reach to this equitable access, to want to walk the talk, to have this kind of equitable access for diagnosis and patient for the rare disease patients coming in a very hard-minded way, like the diabetes and hypertension cancer patients. Thank you.
Just one comment regarding universal health coverage versus rare disease and innovation as well. What we've witnessed is that Sophia went with many actors around the table and online in what happened for the European Union. That rare disease, the setup of establishment of the European reference network, the development of digital tools, infrastructure as well as a service for rare disease patients and their families, innovation and real life and real world evidence studies for expensive drugs, etc. I would say that rare disease and the rare disease community is the driving force for universal health coverage and reform healthcare system. Not the contrary. We have always been at the forefront of innovation in all sectors, including the social sector for rare disease. And this should be understood by the policymakers. We need the rare disease as well to make things and systems change. This is extremely important.
Thank you. If I may, absolutely. I'm looking, however, at the big monies. Where do the monies? And you just named it. I mean, one needs to make the choice where to invest the money. Cardiovascular diseases, cancer, or rare disease. And if I may, this is we need, and again, I think rare diseases need to be the avant-garde to say this. We have 30% of people who do not know that they have dementia. So it is not to wait until they are sick. But the first thing would be every session with the GP, wherever you go, take the blood pressure. It's not costly. And we would spare so much money. In my area, tobacco, alcohol, physical inactivity. I mean, if we would do this in Germany, 90 billion US dollars every year just for tobacco. How is it possible that we're spending $90 billion and we do not have the 30 million for another disease? That's so unjust. So let's be clear, and we need to drive this. We need to say, we need to challenge that and say, you cannot do this if you haven't expired all the prevention mechanisms that you have in place. This will spare so much frustration in the health system. Just look at the shortage of health personnel. Yeah. We can prevent 50% of of all the NCDs. That's 75% of all the diseases that you have. 50% of that could be prevented. And it's just because of very small lobbies of very few companies, 7 tobacco companies, 7 companies drive these. In Germany, just alone, the 90 billion, we have, I mean, globally, we have trillions. The cost that this has. So we have 7 tobacco industries, we have 5 beer companies who actually produce 70% of all the beer globally. So it's very few. And I don't understand. I do this for 30 years now. I don't understand. So rare diseases need to be the driving force because you cannot prevent a rare. This is what really matters.
Oh, exactly. That's what people have to understand. A rare disease is nothing you can really prevent, and it's nothing. It's nobody's blame.
Exactly. That's where the real necessity is, and that's why I'm talking about the second level of UFC.
You can prevent exacerbation in crisis in understanding environmental contaminants, for instance, or social determinants, which means that one health approach is also valid for rare disease.
Absolutely.
We can learn from animal genetics as well. And we should develop this as innovation, for the rest of the chronic disease, cancer, for instance, validation of cancer, drugs, and so on. This should be known by the community.
Yes, absolutely. And we have means. We have fiscal measures. And it's not just taxes. It's also the subsidies. Do you know that $6 trillion every year spent on subsidies for fossil fuels, which create all this damage? The story, no? And we have subsidies even for tobacco growth. Yeah. So we're spending tax money on tobacco. So we need to be avant-garde to say politically we need a different.
Anyone else would like to react?
Hello, Sean Lybrand from Amgen. Thank you very much to all the speakers, and I love your style, Rudiger. Questioning the dominant paradigm health, I think, is really important. So this question goes to that. So as we move towards this rare disease resolution, how do we use as much of our power to consider the incentives to change outcomes as much as we consider how do we remove the disincentives? The WHO best buys were focused on what's the easiest thing to adopt to the hardest. And some of the potentially easy things to consider are what's the regulatory burden of access to rare disease medicines? And is there a mechanism by which that can be significantly reduced? So a couple of examples. One global pact for rare disease medicines for countries outside the stringent regulatory authorities. That, we as an industry struggle with the regulatory burden of medicines, even when they're high income medicines. The idea of having a regulatory process in Africa in some countries which can last for 3 years for such a small number couldn't fix it. So how do we focus on the disincentives and removing those as much as creation?
Thank you for input. Anyone to reply to that perhaps? Or we keep it for further reflection? We will have a lot of.
I don't know if we have this, but in WHO we're pre-qualifying about 70% of all. And it's for global fund, the GAMI, but also because there's no national regulatory authorities. So they rely on the WHO for people. The reason why you have disincentives on regulation here is money. Because the governments do not want to spend all this money on rare diseases because they're already spending enough. Right? So again, this reminds me so much of the very first discussions we had on universal health coverage in the first place, where all the governments told us that they don't have money for you. Yeah, so that's the same rhetoric. Right? Now we need to say we demand our space. we demand space. You cannot spend so much money on preventable diseases if you have not increased the prevention. You cannot spend so much money on diseases where you could have applied a one health approach. This is all available. So now it's time for business. And that means you're saying this is the global space we need in terms of financing, services, and personnel. Right? So that's the way. It's a political question. It's a choice. It's not that this is not there. So, and that brings me back to this, either virtual cycle or the declining cycle that you have here going to describe. Right? Because then member states say 50 million, no, 30 million. And so they decline, they shy away because of the money. So and they don't dare addressing the real issues of prevention. So therefore, our best allies are prevention, One Health, and how to reduce the costs that are unnecessary, intended for those which are.
There is one question in the chat that we will take, but before I present Sophie,
Just a little comment. If we want to have a global approach for rare disease, I think it's very important to underline also the national aspect. And countries has to be organized also to welcome the rare disease. That's why national plans are really, really important, because we have to visualize where are the expertise, which expert can work with the other or expert from other countries. So it's the base. It's really important to have an organized system in the country.
Sophie, I think there is someone else from the audience that would like to speak. Sophie, yeah. So I'm Sophie Fabregon, working at Sanitarium Global Public Affairs, and I'm also vice chairing the Rare Disease Group at RDI. And I really want to share that I'm super excited to hear what you have said today. I hear you was talking about willingness, and I think that in this room there is some really willingness to move forward to problematic of rare disease. I hear that rare is not enough. Also seeing that rare is really an innovative model of the breast and the other therapeutic areas. And I think that we raise plenty of barriers, so we are aware of these barriers. I also hear plenty of different solutions from countries, from regions, from existing systems. And I think that we are all here committed to work together and to move forward. And I'm also here from patients that this is urgent and that we really need now to take action. And this is where I think that we need this global framework, because without policy, we will never move forward. And if we look back 20 years ago, it was an area without any policy. And since we put in place dedicated policy, dedicated plans, we were able to move forward that representation in the families. So I'm really excited to see all of us together wanting to work together. And I hope that the next step will really come soon. Thank you. Thank you, Sophie.
I think you would like to say something?
Yes. Hello, good morning, everyone. So I'm from Ghana. My name is Tuntea. So first things first, I'd like to commend everyone. I'm very, very happy to be here and listening to all this. Where I come from, there is a lot of bridge between clinicians and people. Even the diseases that are not so rare do not get diagnosed easily. So then Dr. Rudiger talked about a universal health coverage, which was a center of excellence that was going to put all the things online or put it in a page where everyone or a GP somewhere who could be able to get access to it. So I wanted to know, first of all, how this can be implemented so that we from Africa or from Ghana would be able to use it to diagnose. Secondly, Dr. Miss Alba was talking about how she felt, she wanted her disease to be known and not everyone taking samples of her. And this is something I've actually seen as a clinician. There was a patient that had a rare disease, and everyone wanted to have a piece. Everyone was coming around. And the patient actually told me, I feel like a guinea pig. I feel like a guinea pig. Everyone is coming around to me. And these are people, and I feel like as clinicians, we should also give them that space. Yes, it's a rare disease. Yes, it's something we might see once or twice in our practice. But we shouldn't make them feel as though they are not human, as though it's something very, very out of the ordinary that we've seen, that everybody wants to have a piece. So I just wanted to, and also, Dr. Rudiger also mentioned that we could prevent some diseases. That tobacco companies and those things, you would see a cigarette pack, and then there will be something boldly written like tobacco kills. But people still go ahead and purchase these things because of addiction, or because they say, oh, I know, but I just need it. So I think that maybe the government should do something about it, regulate it, so that even if these people go ahead to purchase these things, they know kill them, we could have some money left for things like rare disease where no one can actually control. Where I come from, we don't even have a fund for rare diseases. We solely rely on maybe some foundation who would give money to these people to have it, because we're always saying, oh, we've not even tackled the diseases that are common, such as hypertension. Where I come from, as you said, just going to a GP is not expensive. People will tell you what you don't know can't kill you. So, so they won't go, and they won't go. Just before I came, there was a patient that walked into my clinic, and then he was walking with a blood pressure of 217.
Well, thank you very much. That's a reality check. Yes, we have an online question, but please, so when that, then.
Very quickly, because I think regulatory affairs and medicine agencies have a few also to play together. I see the remark in the chat as well. What resolution and a global action plan should promote this is also cooperation between regional drug agencies and medicine agencies. This is extremely important also for promoting mobility and access to drug wherever you are around the globe. So this is extremely important. We have seen reform and evolution in the European Union, the European Health Union, if I could say, and we would be also, as European, ready to share with, for instance, the African Medicine Agency and other agencies such as the FDA on these key topics.
Thank you for reminding the role of the regulatory agency. Absolutely. We just would like to give a chance for participants online. There have been a lot of questions and comments that we will manage to keep and to use for a next discussion. There will be many more discussions, I'm sure. But Alana, would you like to pick up one question?
Yeah, it's on the screen, but I'll read it out loud as well. So this participant would like to know, in Europe, we have the freedom of traveling of goods, but not for validated therapy. What could be done from a European regulatory affairs perspective, enabling freedom of traveling of validated therapy? Imagine what this would mean for patients, families, patients and families, pharma and medtech companies, and healthcare professionals.
Who would like to just react to that question? You just touched on it, but I think this, yes. Thank you.
Well, we do have the cross-border healthcare directive, we do have the ERNs, and in that prospect, there's a lot of therapies already available from someone from the Netherlands, or from someone who lives in Poland. They could go to the Netherlands if their hub does allow it, and if the insurance says yes. So in theory, it is there. But in practice, the problem is that medicines that are authorized in Germany are not authorized in Spain and the other way around. So we do have that problem. So this is not available in Spain, but it is in Germany. With the EU HTA, we are trying to bring it more in a better balance so that everyone has the same HTA, so that but there will still be price discussions with pharma companies. There will still be differences in the countries because each country has the authority for their healthcare system. And this is not going to change, probably never. But we have the chance to go to another country, but then you have to go there every time you need the medicine. No question.
Yeah, I just have a comment. It's really important to be organized at the EU level, like the real world evidence data, because we need to prove the benefit of the drug. It's a very interesting subject that we can organize with the ERNs and the 24 ERNs.
Yeah. Thank you very much. We have to close down. Unfortunately, I'm sure that we would have been able to continue and discuss. It really shows again the importance of continuing this every day along the reference of rare disease. We have a framework that is going to really enable this about the process that's going to lead us to May 2025 hopefully with the resolution and the global action plan. And then we adopted with a long year ahead, where we will be able to definitely, hopefully, integrate all the things that have been done today. So just quick recap, system approach. We have to look at the health system to fix this. We have to see the global perspective with the other current challenges like Dr. Rodriguez really puts on like diabetes and all the NCDs, but really have to be prioritized, have to be in the health system of country. Then we have the real world data, absolutely. Data is, I think, hopefully a work stream that we are going to be able to tackle when we're going to develop the Global Health Action Plan. Then it's important to integrate rare disease into the healthcare system. So thank you for bringing this, really. And again, hopefully the Global Action Plan will tackle this one. It's very important to look at the social impact of rare diseases, with the mental health also critical. And I would say, just to finish and to close, it's about political will. We know that the expertise, we know that the technicalities, we know that the implementation will be challenging and there will be a lot of experts, but today the rare disease community has those experts. I mean, it's an amazing community that is ready more than ever, I would say. And the evidence here that we have some countries like Egypt, France, and Qatar, Malaysia, Chile, Spain, that are today putting rare disease at the highest level of global health. So thank you very much. It's a Sunday morning, so please enjoy the World Health Summit. It's a great opportunity, and we'll hope to see you again next year. We'll definitely see you at the World Health Assembly in Geneva, definitely, all together. And again, huge thanks for your support. Thank you for IPMA to make it this event and see you soon.
Well, it's